focused on blocking the complement system? Well, there's really two reasons. We started honing in on it back in 2005 when our genome-wide association studies started seeing that there were some common variant mutations in the population that dramatically increased the risk of developing geographic atrophy. So that was number one. And since then, there's been over 40 loci identified in multiple different complement genes, CFH, C3, C2, and probably CFD, which is part of C2, so, and also CFI. So that was the first time we ever saw that there is certain gene mutations that can be associated with macular degeneration. Now, we don't typically think of macular degeneration as a Mendelian disease. It's a very complex disease, but these identified mutations were shown to have a much higher risk of developing geographic atrophy. The other reason we started looking towards the complement system was when we looked under the microscope and we looked at the histopathology of drusen, and we saw that drusen contains a lot of different components of complement. So based off those two things, there's been a lot of drive and push to develop therapies that block different parts of the complement system. Here are my financial disclosures. So going into some of the trials that are ongoing right now, the first one we'll talk about is Ionis, which is Ionis is a company based out of California that's doing a systemic administration of an RNA targeting therapeutic for the treatment of GA. So they're targeting specifically factor B in geographic atrophy, and it's designed to reduce the complement factor B. So most of these GWAS, in fact, all of the GWAS studies that have been associated with macular degeneration have been specifically in the alternative pathway of the complement system. So the complement system is a very complex system. If you're not in the space of retina, you might not know this chart very well, but there's three pathways. There's the classical, the lectin, and the alternative pathway. And we're focusing here with factor B on the alternative pathway, where pathogenic surfaces can cause spontaneous hydrolysis that leads to C3 activation and splitting of C3 into C3A and C3b. And it's that C3b that goes on and activates C5, which then leads to further propagation of the complement system, leading to MAC formation and ultimately cell death. Also leads to activation of the inflammasome. So factor B is located in the alternative pathway, and it's considered an amplifier of the complement system. So it really amplifies the alternative pathway. Most of the complement proteins in our body, majority are made by the liver, so that's something to know. There is some local production, we think, within the eye, but the majority is within the pathway, not the classical pathway. So why would an exon be targeting the classical pathway? Well, let's talk about the classical pathway. The classical pathway starts with C1q, it's up at the top, and that moves down and eventually converges on C3. So C3 is the location of the complement pathway where all three pathways converge together. So why would we block C1q? Well, we've seen some interesting things. We know that there's a high local expression of C1q in the retina by macrophages. That's one of the cells that likes to make C1q, or macrophages. There can be high levels in different parts of the outer retina and the RPE and choroid. And if you block C1q, you're going to block the entire classical pathway, but you're going to allow for the alternative and the lectin pathways to continue. So they're taking a different strategy than almost every other company that's in development with blocking complement. So an exon designed a molecule called ANX007, which was designed to block C1q. It's a recombinant humanized antigen binding fragment, a Fab, of a monoclonal antibody. And its molecular weight is approximately the same as the molecular weight of ranibizumab. And it binds to the complement protein C1q. Their early phase 1 studies in ophthalmology were conducted in glaucoma. Why in glaucoma for phase 1? Well, there's some evidence to suggest that blocking C1q may have a neuroprotective effect, so they went to glaucoma first. But now they've moved on to geographic atrophy, and right now they're in phase 2 of what's called the ARCHER study, where they're evaluating the effect of ANX007. So this study is now fully enrolled, and patients were randomized in a 2-to-2, 1-to-1 fashion over 240 patients to either receive a monthly intravitreal injection of ANX007 or an injection every other month for a year versus sham monthly or every 2 months for a year, with the primary outcome being the change in the geographic atrophy lesion from baseline to month 12. So we should hopefully have those results, I think, in 2023. Next, we'll move on to NGM Bio. They're looking at C3 inhibition for the treatment of GA. So we said complement C3 antibody. And it's a full-sized IgG1 monoclonal antibody. It's about the size, it's very similar size to bevacizumab, so you can think of it like that, where it has high ability to block C3. We'll talk about another C3 inhibitor shortly. So what may be the potential advantages with NGM 621 over the other C3 product we're going to talk about? Well, this is a full monoclonal antibody, and it's a potent, very potent inhibitor of C3, and that potentially could translate into better outcomes than some of the other approaches that are being used. This strategy also allows for dosing frequency to potentially be extended for up to every 8-week dosing, and it's a unique molecule, which many of you may be aware of. They also are looking at the role of C3 inhibition for the treatment of GA. So they have a molecule called pegcetacoplan, which is a pegylated, highly selective peptide that binds to C3, preventing its cleavage. So again, at the convergence of all 3 of the complement pathways, they're blocking right at the convergence. So we think of it as kind of being the maximum way you can block as much complement of the complement system as you can. You're going to prevent all the downstream effects from there on after C3, like we talked about before: activation of the inflammasome, development of the MAC complex, and ultimately cell apoptosis and death. So we'll go into their global phase 3 programs, which have read out, and they looked at, they had 2 parallel studies. There were massive global randomized multi-centered trials called OAKS and DERBY. There were over 600 patients in each study, so over 1,200 patients in total, where they randomized patients 2-to-2, 1-to-1 to either receive their pegcetacoplan intravitreal injection monthly or every other month, and that went on for 24 months versus sham monthly or every other month for 24 months. The primary endpoint readout was the change in total area of the GA lesion at month 12. They also looked at, as for their secondary outcome measures, they looked at functional outcome measures using this product only at month 24, not month 12. Key inclusion criteria exclusion for these trials was age over 60, and the lesion size of the GA had to be between 2.5 and 17.5 millimeters squared. So it's about 1 to 7 disc areas. Both foveal and extrafoveal GA lesions were permitted. Multifocal lesions were permitted as well, but you had to have at least one lesion, had to be at least greater than or equal to 1.25 millimeters squared, which is about a half disc area. And you had to have some presence on the autofluorescence around the lesion. Key exclusion criteria were similar to many of the trials that we see. One thing that's important to note is these trials did allow for patients to have a history of active or inactive photoneovascularization in the fellow eye, and that becomes important when we talk about the safety. So this drug was able to meet its primary endpoint in the OAKS study. So we'll talk about OAKS first, where the monthly treated pegcetacoplan patients had a 22% reduction in the change in their area size at month 12, which was statistically significant. And also the every other month group had a strong reduction of 16% at month 12 compared to sham, which was statistically significant. However, in the other study, the Derby study, the results were different, and it did not meet its primary outcome in Derby. So there was a reduction of 12% in the monthly group, and which just missed its p-value. P was 0.0528 versus sham, very close. And in the every other month group, it was an 11% reduction at month 12. Again, very close to significance, but not significant if the p-value was 0.0750. Apellis did, in their statistical analysis plan, they had a pre-specified analysis to combine the data. So if we look at combining the OAKS and the Derby data, you can see that the monthly treated arm had a reduction of 17% at month 12, which was statistically significant. P-value was less than 1 in terms of the sham treated patients compared to the active treated patients. And that's something for all of us to keep in mind, is that when we do these clinical trials, we have a very limited primary outcome time measure, right? Usually a year or 2 years. But our patients live with these diseases for much longer than that in real life, 5, 10, 15, 20 years. So I, in my mind, imagine these curves going on for 10, 15, 20 years over time. And we can see at month 24 in Derby, we see much stronger reductions. We now see 19% reduction at month 24 in the monthly group and a 16% in the every other month group. OAKS was 22% in the monthly group and 18% in the every other month group. So now we have statistical significance.
Specialty day. So David really did a great job highlighting the role of complement system in geographic atrophy, and some of the targets, actually all of the targets, are doing, regulating the complement system. Here are my disclosures. So first one I want to talk about is complement factor I. It's a key downregulator of complement system, and it's an interesting protein that's produced by the RPE cells. And inducing factor I expression has shown to have continuous decrease in key protein that are involved in complement or activation that David covered. So C3BA, C3B, and IC3B. So the goal here is not to block the complement system, but rather regulate the complement system so that we can slow down the progression of geographic atrophy. GT005 is an AAV2 based gene therapy that's designed to induce expression of complement factor I. So essentially you have a transgene that you have a vector that carries the transgene into the eye, and you transfect the cells of the retina to produce the complement factor I. So you're increasing the levels of complement factor I. Hope is to slow down the progression of geographic atrophy. You're all aware that gene therapy is a paradigm shift. It's a new way to treat diseases, but we're still learning about long-term efficacy and safety of this one time. It's an open label, so there's no control arm in this. This is more about looking at the safety to see if we are producing the protein that we design this gene therapy to produce, and are we having an impact on the biomarkers that are controlling the disease. So this study is fully recruited, and it's interesting how the study is designed. Of course, not just dose escalating the gene therapy, starting at 2E10 and then going up to 2E11, but also the delivery approach. So the traditional subretinal transvitreal delivery is you do a vitrectomy, you have your subretinal cannula, you inject gene therapy under the retina, you make a bleb, but of course we know that patients who undergo vitrectomy have a higher risk of cataract progression. So that is actually done in clinic, and again, this gene therapy program impacts CD59, and what it is, the CD59 is a naturally occurring protein that inhibits the formation of the MAC complex, and that's the terminal pathway. So as David went through the complement system, you can see the terminal pathway is MAC attack formation, and complex formation. And if you inhibit that step, you can hopefully potentially slow down geographic atrophy. So the J&J 1887 phase 1 results were just reported yesterday. It's the first in human study looking at obviously safety and tolerability in patients with geographic atrophy. And you can see there is 3 different dosing cohorts, and we have data from 6 months and then follow-up at 12 months and then extended follow-up. And really the idea is intravitreal gene therapy. We know intravitreal gene therapy is more prone to inflammation, and especially we have seen programs in neovascular AMD and diabetic macular edema where we saw some serious events. So that's why we want to make factor of the complement pathway, which is C5. And we have literature that shows that if you inhibit C5, you slow inflammation and cell death associated with progression of and development of geographic atrophy. The other benefit, as David said, complement system is there to, for a reason. And the other benefit of blocking C5 is that it potentially preserves the anti-inflammatory properties of C3A. So you are targeting downstream. David talked about APL2 as C3, and then an exon is C1q. So we are going further down, but it's above the J&J gene therapy that I spoke about. In terms of GATHER2, it's a phase 3 global multi-center double mask sham controlled study. We recruited 448 patients for this trial, and patients either receive avacincaptad pegol monthly for first 12 months or sham. So, you want to make sure that you are maximizing efficacy, and you're also seeing in terms of, your control arm not receiving any treatment, so you can see if there's a benefit. So the primary endpoint is mean rate of growth in geographic atrophy area from baseline to month 12 using a slope analysis and square root transformation. So slope analysis is something FDA actually asking now. It was part of the SPA package for the GATHER2. And the slope analysis, as David said, this disease progresses over time, and the separation gets bigger and bigger the more you treat based on our experience. So the idea is, are we changing the course of the disease 1 year, 2 year, 3 year, 5 year down the road? And so slope analysis is what was asked by the FDA for this clinical trial. This is a 2-year study, so in the second year, patients were re-randomized to either receive monthly or every other month avacincaptad pegol, and then patients who received sham continued on sham injections. In terms of key exclusion, inclusion, these are very comparable to other trials that you saw, except for a few differences that are highlighted. Number one, this is non-central point involving GA. So what does that mean? That means that GA can be large, but it just doesn't include the center of the fovea, and I'll show you some examples. And then GA in part has to be within 1500 microns from the center point. Other exclusion are listed here, but these are very comparable. So how did the lesions look like? So if you look at those 2 lesions on the left, you can see the green. The cross in the center, the center of that cross is the center point. And then that circle around is 1500 microns, the edge of the 1500 microns from the center point, and this is actually evaluated by the reading center. So investigators thought to send the photos, OCTs, FAF, and then the reading center made the decision if these patients are eligible or not. So you can see those 2 lesions on the left were eligible, and then you can see on the right those 2 lesions are not. One is outside the 1500 microns, and then the other one is involving the center point. So just to kind of put this, these examples, because sometimes when people say extrafoveal, basically what we are seeing in both trial a consistent treatment effect in terms of early effect, and then that increases over time, and it's really driven, these subgroups are all benefiting from it. Safety is important for a new drug. The safety profile looked excellent here. We look at the treatment emergent events here. You can see the comparison between avacincaptad pegol and sham. And you look at the ocular TEAs, again, you can see them highlighted here. Again, the rate is comparable. Of course, David talked about choroidal neovascularization. That's something we keep an eye on, and there's a higher rate of that. And when you look at seriousness of it, there was 2 events in the avacincaptad pegol group compared to sham. There was one event where it was considered serious based on the investigator report, and that was related to choroidal neovascularization. Intraocular inflammation, endophthalmitis, ischemic optic neuropathy are things we are really looking carefully for because it's a new drug. And many of these patients will have good visual acuity if they're non-foveal, so we want to make sure that safety profile looks good. I'm happy to report that there's no safety events here. There's no inflammation, no endophthalmitis, no ischemic optic neuropathy in either group. So the drug appears to be very safe, and this is very consistent with the profile we saw in GATHER1. The rate of CNV obviously is higher with in the avacincaptad pegol group. As you can see, 66.7, 15 cases, therapy in GA to achieve the 12-month pre-specified primary endpoint versus sham, coupled with a consistent safety profile in 2 pivotal phase 3 studies, so GATHER1 and then GATHER2. CNV rates were 6.7 in the treated group compared to 4.1 in the sham group in GATHER2. And at month 12 or 12 months, there were no cases of intraocular inflammation, endophthalmitis, and ischemic optic neuropathy in study eyes treated with avacincaptad pegol. So basically, we have 2 trials met the pre-specified primary endpoint, showing the efficacy of avacincaptad pegol in treatment for geographic atrophy. So I want to thank you for your attention, and I'll give the mic back to Carl.
I want to thank everyone for being here. I do want to mention that I don't know if this is the last course in this room, but the last bus does leave at 6 p.m., so I've been instructed to let everybody know that. You learn something new every day. I learned a lot from you guys. Thank you so much. You know, every time I see these slides, there's always a little bit more that I glean from the data. So, you know, here's a picture of a patient of mine. You know, she has actually passed away a few years ago, but nevertheless, she's someone that I really wanted to get into a clinical trial before she passed away. Because she's someone that, you know, we can just see it. We can just sense it as a doctor. When we see that image, we just see the walls closing in on her central vision with that atrophy. So I want to open up the floor to any other questions that you have regarding the identification of GA, the coding of it, why it's important, or any of the clinical trials that were discussed today. And I want to thank everyone again. Dr. Jean-Francois.
Yeah, any thoughts on why the rate of CNVM was higher in the treated group compared to sham?
So we're not completely sure why, you know, there's some debate going on, you know, by inhibiting complement that cause that. But, you know, it's not insignificant in the sham arm also. Like we see this commonly, you know, among the general population, you know, and how we treat this in the real world, you know, depends on the location of the neovascular membrane. Sometimes, you know, patients may have a neovascular membrane on the edge of the atrophy that's away from the fovea. You know, we might treat that patient differently than if we have a neovascular membrane that's threatening the fovea. But the true reason that I'm talking about, you couldn't even open the book to start reading it. It was closed, and patients were hopeless. You know, and I even had a patient who was 97 years old 4.5 years ago, and I said, you know, I think we should put you in a trial. She's like, well, doc, you know, 97, estimated vision at the time. And lo and behold, she's 102 years old right now, and she's my oldest patient. She's 2,400 in both eyes. So, I mean, patients may not think they're going to live long enough to benefit from this, but she probably would have benefited from being in a clinical trial. And I have other patients that, you know, when I have, at one point I had, you know, 4 GA trials going on. I'm sure you guys have, you know, that too, if not more. And I just said, choosing observation is not really a good option anymore. You know, because we're trying to further the field, you know, learn more about the genetics of it, and give people vision longer, preserve what they have longer. So we need to detect it sooner, get it to the retina specialist,